नमस्ते बिटिया, हमेशा खुश रहो बिटिया। I am Dr. Bharat Sharma, Assistant Professor, Department of Pathology, Faculty of Homeopathic Science, JAYOTI VIDYAPEETH, Women's University, Jaipur. Today's topic is acute myocardial infarction. Acute myocardial infarction is the most important and feared consequence of coronary artery disease, a significant factor that may prevent or diminish the myocardial damage is the development of collateral circulation through anastomotic channels over a period of time. Irregular and well-planned exercise program encourages good collateral circulation and improved cardiac performance. Incidences. In developed countries, acute myocardial infarction accounts for 10 to 25% of all deaths due to the dominant etiologic role of coronary atherosclerosis in acute myocardial infarction. The incidence of acute myocardial infarction correlates well with the incidence of atherosclerosis in a geographic area. Age. Acute myocardial infarction may virtually occur at all ages, though the incidence is higher in the elderly. Sex. Male throughout their life are at a significantly higher risk of developing acute MI as compared to female. Women during reproductive period have remarkably low incidence of acute MI, probably due to protective influence of estrogen. Etiopathogenesis: the etiologic role of severe coronary atherosclerosis. More than 75% compromises of lumen of one or more of the three major coronary arterial trunk. In the pathogenesis of about 90% cases of acute myocardial infarction is well documented by autopsy studies as well as by coronary angiographic studies. First is myocardial ischemia. Myocardial ischemia is brought about by one or more of the following mechanisms. First is diminished coronary blood flow. Example is in coronary artery disease or in shock. Second is increased myocardial demand, that is in exercise or emotions. Third is hypertrophy of the heart without simultaneous increases of coronary blood flow, that is in hypertension, valvular heart disease. Second is role of platelets. Rupture of the atherosclerotic plaque exposes the subendothelial collagen to platelets, which undergoes aggregation, activation, and release reaction. Acute plaque rupture, but acute complication in coronary atherosclerotic plaques in the form of superimposed coronary thrombosis due to plaque rupture and plaque hemorrhage is frequently encountered in cases of acute MI. Superimposed coronary thrombosis due to disruption of plaque is seen in about half the cases of acute MI. Infusion of intracoronary fibrinolysis in the first half an hour of development of acute MI in such cases restores blood flow in the blocked vessels in majority of the cases. Intramural hemorrhage is found in about one-third cases of acute MI. Non-atherosclerotic cause. About 10% of the acute MI are caused by non-atherosclerotic factors such as coronary vasospasm, arteritis, coronary ostial stenosis, embolism, thrombotic disease, trauma, and outside decompression as already described in previous lectures. Transmural versus subendocardial infarction. There are some differences in the pathogenesis of the transmural infarcts involving the full thickness of ventricular wall and the subendocardial infarcts affecting the inner subendocardial one-third of half. These are as under. First is transmural infarcts. They are the most common type seen in 95% cases. Critical coronary narrowing, more than 75% compromised lumen is of great significance in the causation of such infarcts. Subendocardial infarcts have their genesis in reduced coronary perfusion due to coronary atherosclerosis, but without critical stenosis, not necessarily 75% compromised lumen, aortic stenosis, or hemorrhagic shock. Types of infarction. Infarcts have been classified in a number of ways by the physician and the pathologist. First is according to anatomic region of the left ventricle involved. They are called anterior, posterior, lateral, septal, and circumferential, and their combination like anterolateral, posteriolateral, and anteroseptal. Second is according to the degree of thickness of the ventricular valve involved. Infarcts are of two types: full thickness or transmural, when they involve the entire thickness of the ventricular valve, or subendocardial or laminar, when they occupy the inner subendocardial half of the myocardium. Third is according to the age of infarcts. There are of two types: newly formed infarct called as acute, recent or fresh, and advanced infarct called as old, healed or organized. Location of infarcts. Infarcts are most frequently located in the left ventricle. Right ventricles is less susceptible to infarction due to its thin wall, having less metabolic requirement, and is thus adequately nourished by the Bayesian vessels. Atrial infarcts, whenever present, are more often in the right atrium, usually accompanied the infarct of the left ventricle. Left atrium is relatively protected from infarction because it is supplied by the oxygenated blood in the left atrial chamber. The region of infarction depends upon the area of obstructed blood supply by one or more of the three coronary arterial trunks. According to there are three regions of myocardial infarction. First is stenosis of the left anterior descending coronary artery is the most common, 40 to 50%. The region of infarction in the anterior part of the left ventricle, including the apex and the anterior two-thirds of the interventricular septum. Second is stenosis of the right coronary artery is the next most frequent. It involves the posterior part of the left ventricle and the posterior one-third of the interventricular septum. Third is stenosis of the left circumflex coronary artery is seen at least frequently about 15 to 20%, and its area of involvement in the is the lateral wall of the left ventricle. Gross appearance. As explained above, they are found most often in the left ventricle. The transpleural infarct, which by definition involves the entire thickness of the ventricular wall, usually have a thin rim of preserved subendocardial myocardium, which is perfused directly by the blood in the ventricular chamber. The subendocardial infarcts, which affect the inner subendocardial half of the myocardial, produces less well-defined gross changes than the transpleural infarcts. 1 in 6 to 12 hour old infarcts, no striking gross changes are dis- discernible except that the affected myocardium is slightly paler and drier than normal. However, the early infarcts, 3 to 6-hour-old, can be detected by histochemical staining for dehydrogenase on unfixed slice of the heart. This consists of immersing a slice of unfixed heart in the solution of tripe nitrotetrazoline chloride (TTC), which imparts red-brown color to the normal heart muscles, while the area of infarct muscle fails to stain due to lack of dehydrogenase. Second is by about 24 hours, the infarct develops cyanotic red-purple blotchy area of hemorrhage. Third is during the next 48 to 72 hours, the infarct develops a yellow border. Fourth, in 3 to 7 days, the infarct has hyperemic border while the center is yellow and soft. By 10 days, the periphery of the infarct appears reddish purple due to growth of granulation tissue. With the passage of time, further healing takes place. the necrotic muscle is reabsorbed and the infarct shrinks and becomes pale gray. 6 says by the end of 6 weeks, the infarct area is replaced by a thin gray white hard shrunken fibrous scar which is well developed in about 2 to 3 months. Microscopical appearance subsequently timeline changes are as under. In first week, in the first 6 hours after infarction, usually no detectable histologic changes is observed in routine light microscopy. However, some investigators have described stretching and waviness of the myocardial fibers within 1 hour of the onset of ischemia. After 6 hours, there is appearance of some edema fluid between the myocardial fiber. By 12 hours, coagulative necrosis of the myocardial fiber sets in and neutrophilic begins to appear at the margin of the infarction. During first 24 hours, coagulative necrosis progresses further as evidenced by Shankar eosinophilic cytoplasm and pycnosis of the nuclei. During first 48 to 72 hours, coagulative necrosis is completed and with loss of nuclei, the neutrophilic infiltrate is well developed and extends centrally into the interstitium. In 3 to 7 days, neutrophilic are necrosed and gradually disappear. The process of resorption of necrosed muscle fiber by macrophages begins. Simultaneously, there is onset of proliferation of capillaries and fibroblasts from the margins of the infarct. Second week, by 10th day, most of the necrosed muscle at the periphery of the infarction is removed. The fibrovascular reaction at the margin of the infarction is more prominent. By the end of second week, most of the necrosed muscle is small infarct is removed. Neutrophilic have Neutrophils have almost disappeared and newly laid collagen fiber replace the periphery of the infarction. In third week, necrosed muscle fiber from larger infarcts continue to be removed and replaced by ingrowth of newly formed collagen fiber, and in 4 to 6 weeks, with further removal of necrotic tissue, there is increase in collagenous connective tissue, decreased vascularity, and fewer pigmented macrophages, lymphocytes, and plasma cells. Salvage in early microinfarction and reperfusion injury. In vast majority of the cases of acute myocardial infarction, occlusive coronary artery thrombosis has been demonstrated superimposed on fibrofatty plaque. The ischemic injury to myocardium is reversible if perfusion is restored within the first 30 minutes of the onset of infarction, failing which irreversible ischemic necrosis of myocardium sets in. The salvage in early infarction can be achieved by the following intervention: institution of thrombolytic therapy with thrombolytic agents, percutaneous transluminal coronary angioplasty, coronary artery stenting, and coronary artery bypass surgery. Changes in early infarction. These are as under: electron microscopic changes, disappearance of peri- perinuclear glycogen granule within 5 minutes of ischemia. Second is swelling of the mitochondria in 20 to 30 minutes, disruption of sarcomere, and nuclear alteration like peripheral clumping of nuclear chromatin. Second is chemical and histochemical changes. Glycogen depletion in myocardial fibers within 30 to 60 minutes of infarction, increases in lactic acid in the myocardial fibers, loss of potassium from the ischemic fibers, increase of sodium in the ischemic cells, and influx of calcium into the cells, causing irreversible cell injury. Diagnosis. The diagnosis of acute myocardial infarction is made on the observation of three types of features. First is clinical feature. Typically, acute MI has sudden onset with pain, indigestion, apprehension, shock, oliguria, low-grade fever, and acute pulmonary edema. Second is ECG changes. The ECG changes are one of the most important parameters. Most characteristic ECG changes is ST segment elevation in acute MI. Other changes include T wave inversion and appearance of wide deep Q wave. Third is serum cardiac markers. Certain proteins and enzymes are released into the blood from necrotic heart muscles after acute MI. Measurement of their level in serum is helpful in making of diagnosis and plant management. Creatine phosphokinase and CKMB. CK has three forms: CKMM derived from skeletal muscle, creatine phosphate phosphokinase BB derived from brain and lungs, and CKMB mainly from cardiac muscle and insignificant amount from extracardiac tissue. Complication followed an acute MI, only 10 to 20% case do not develop major complication and recover. First is arrhythmias, second is congestive heart failure, third is cardiogenic shock, fourth is mural thrombosis and thromboembolism, fifth is rupture, sixth is cardiac aneurysm, seven is pericarditis, and eight is post-myocardial infarction syndrome. This session is powered by Digital Version 2.0, Jyoti Vidyapeeth Women's University. I hope you all enjoyed this session. If you have any query, please mention it in comment box. Thank you.